Okay, we are going to get started. Good evening, everybody. Thank you for joining us. Welcome to the forum, Understanding Immunological Testing. I will be your MC tonight. I'm Kathy Antela, Vice President of Education at the Immune Deficiency Foundation. And at this time, I would like to give everyone a huge welcome. As I always say, whether it's your first forum or your 100th forum, we are so glad to have you here. And as always, a quick disclaimer that the information shared during this event is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Please always seek the advice of a physician in order to manage any healthcare condition you or a family member may have. IDF has been around for over 40 years and is considered a leader in the PI community. Everything we do is based on IDF's mission, which is to improve the diagnosis, treatment, and quality of life of people affected by primary immunodeficiency through fostering a community empowered by education, advocacy, education, and research. And it is by, let me flip here. And with this mission, we are committed to serving you and providing you with the tools and resources needed to be your own best advocate and a champion in the PI community. And it is by offering these tools and resources that IDF can fulfill its mission in seeking to ensure that everyone in the United States affected by PI has a fully informed understanding of the PI diagnosis that affects them, all available treatment options, the expected standard of care, and all of their opportunities for connection and support within the PI community. Questions? Ask IDF. IDF is here, whether you are an individual with PI, a family member, friend, or healthcare provider. We are here to help you answer give you answers to your questions. And all you need to do is go to the IDF website. On our homepage, up at the top, there is a box that says Ask IDF. Click on that box, submit your question, and a staff member will follow up with you. Get connected groups. If you are looking for support nationwide throughout the year, we have virtual support groups for individuals with PI and family members. And these Get Connected groups happen in the evening or on a Saturday, weekend day, when people are available to join them. And this is the perfect time to get to know others, to receive support, to share information. And we hope you will try one. If you haven't joined one yet, check out the calendar of events. I saw there is one for parents coming up within the next couple weeks. And the other thing is if you're looking for support and you would prefer to have one-to-one support, that's also a great option. And that is also provided. All you need to do there is go to Ask IDF and say, I would like some peer support. And you will be networked with one of our wonderful peer support volunteers. Upcoming forums. The next forum is in the afternoon on February 23rd. It is a lunch and learn about WHIM syndrome. So check that out in the calendar of events. Hope you sign up and join. It'll be a great forum, and it will be supported by X4 Pharmaceuticals. And then after that, the next forum in the evening on a Thursday is March 3rd. And the topic there is understanding primary and secondary immunodeficiencies. So we hope that you will register for both and look forward to seeing you on February 23rd and March 3rd. Now, our sponsors, we have wonderful, wonderful sponsors. Cannot thank them enough for the support they provide for the forums and other services. And at this time, I would like to thank our current 2022 sponsors, CSL Behring, Grifols, Takeda, Horizon, Accredo, Farming, and Enzavant. At this time, I would like to introduce our presenter, Ms. Kristin Epland. And Kristin Epland is from Minnesota, and she is employed by Infectious Disease Associates. And she is going to talk to us about understanding immunological testing. And Chris has been caring for patients with PI for over 20 years, and she is also a member of the IDF Nurse Advisory Committee. So Chris, thank you so much for being here, and take it away.
Hi, everybody. I wish I could see everybody. I'm really the speaker who likes to play to the crowd, you know, kind of like a stand-up comedian, but I'll keep the jokes to a minimum because I can't tell if you're laughing or not. So this is a program that I first did for IDF back in 2018. And unfortunately, we lost the program. We lost the whole slide deck. So we started from scratch, which was really great for me because it made me stop and sort of do a new outline and revisit all of the new stuff that has happened in the last 4 years even on immunologic testing. And so I'm going to go in order. I won't stop for questions until we get to the end. There's a lot of you on tonight, I understand. And so if your question doesn't get answered, we can work with Colleen and Kathy to try and figure out a way to address it if it's an issue that needs to be presented to me. I'm happy to field some emails from IDF with questions. So let's go, let's get started. These are the 3 things we're really going to cover today. When you talk about immunologic testing, everybody thinks about blood draws. But it's important to understand that testing also comes from a history and a physical exam too. But then there is that laboratory section that is important in diagnosis. And then of course, genetics, which has been the biggest addition to this presentation. So let's start with history taking. Some of the important things to tell when you are meeting an immune deficiency provider for the first time. Birth history should be addressed. A premature delivery, NICU needs after delivery, any congenital defects that were noted at the beginning, all need to be brought to light in history taking. Vaccination history. Were your vaccinations given on time as far as you know, or did you vaccinate your child in the recommended series of vaccines? Because if you didn't, that could create a difficulty, and we'll talk about that a little bit later. Were there any untoward reactions to vaccines that we should know about? Or is your child or you completely unvaccinated, which plays a role in diagnosis? Infection history. What types of infections have affected you or your child? What kinds of treatments have been offered for those infections? And what's the frequency of infection? Sometimes people think, well, sinus infections aren't important, right? Like I only infections I ever get are sinus infections. Well, sinus infections are a nuisance, but if you're getting them all the time, they are impactful. And for that reason, you can't say I just get sinus infections. You have to dive a little bit deeper and say, I get sinus infections. Sometimes it takes 3 antibiotics to get them better. Sometimes I get them once a month and I'm continuously on it. All of that stuff is really important to point out in a history taking. Here is a real messy slide, but these are 2 separate publications on the warning signs of primary immunodeficiency disease. And so when I have students with me in healthcare, whether it's nursing or medicine, inpatient or outpatient, we talk about these things. This is about severe persistent, unusual, recurrent history of infections. But even more important, like I mentioned before, sometimes they're not severe. Maybe they're just a nuisance, but they are impactful from a quality of life standpoint. But maybe they are severe. Maybe you need IV antibiotics to clear an infection. That's not normal. What's normal? That's what we're going to talk about now, moving forward on this. And what is normal for you may not be normal. And we need to make sure that we are addressing what's called the normal distribution curve. And this will be important because they use a curve. This is not a statistics class, but we're going to do a little bit of statistics up front here. This is how a normal range is determined. So a collection of data follows a normal distribution curve, where 0 is considered the median. And everything above and below that falls under a distribution. So basically, if you fall under the normal distribution curve, you are 90% normal. 5% would be lower than normal, 5% would be upper than normal. And one of the things with immunologic testing is sometimes that normal range moves because age may determine what normal ranges are. Ethnicity may determine what normal ranges are, and location in the country may determine, or in the world, I should say, could determine what is normal. So when we talk about normal, what is a normal IgG level, which we'll get to, it's not the same for you today as it was 5 years ago. And it's not the same for your child as it is for you. And so we have to take into account these normal distributions. So let's do it. Let's dive into laboratory testing. This takes a lot of time. It's a complicated subject to cover. And so I have put it into a bit of a story to help you kind of sort out what's important. So whenever we start assessing the stability of the system, we start by looking at the foundation. You're going to build a house, you better start with a good foundation. And your immune system's foundation is in the blood counts. Blood counts are the marker of your bone marrow function. And there are 3 lines of cells that are important: red blood cells, platelets, and white blood cells. Now, they all have immune function, but they all carry different weight. Let's start with the red blood cells. The red blood cells are responsible for transporting oxygen from your lungs into your tissue, right? We all know about hemoglobin. Hemoglobin is that iron carrying part on the red blood cell that brings oxygen to your tissues. Your red blood cells also take the carbon dioxide waste back to your lungs so that you can breathe it out. The diagnosis of anemia is based on a lack of red blood cells and or hemoglobin. That's usually what we measure when we talk about red blood cells. If you have low red blood cells or low hemoglobin, you'll be fatigued, you'll feel short of breath, you'll have muscle cramps. This can be a consequence of iron deficiency, but it can also be an immune-mediated problem. Platelets are these big pieces of the blood that clot for us. Low platelets can lead to bleeding and bruising issues. Low platelets or platelet dysfunction, like lack of stickiness, can be related to some medicines we take. Famously, aspirin can do that. Advil or ibuprofen can do it as well. But having low or absent platelets is a common immune manifestation in the blood called ITP. And so sometimes that is the first thing that leads us to say, something's wrong with the immune system here. It's a dysregulation. But here we go. Now we're talking white blood cells. This is where we all got it going on, right? So the white blood cell is the chief in charge of our immune system. And there are 5 different types of white blood cells that we are interested in. Neutrophils and lymphocytes make up the most percentages. So about 60% of your white blood cells should be either neutrophils or lymphocytes. And they should be in balance most of the time. When they get out of balance, sometimes that gives us some clues. Monocytes, basophils are mid cells, and eosinophils are reactive cells, sometimes associated with allergy. So let's dive into each one. Lymphocytes. I'm going to start with lymphocytes. The lymphocytes are the generals. The immune function. So lymphocytes consist of T cells, B cells, and natural killer cells. And they protect us against a whole array of infections, viruses, bacteria. They all work together to make our immune system function properly. So this is the foundation, okay? Neutrophils are the garbage collectors. So when an infection is identified by the lymphocytes, they're put to the curb and they're marked as garbage. And then the garbage collectors come by and they pick up the garbage. So these are the cells that help protect our body from infections by eating these infections, bacteria, fungi, any foreign debris, viruses, and they make pus. So when you have a boil and you pop it and pus comes out, that's not infection coming out, that's immune response coming out. That pus can then be cultured and you can figure out what infection came out. They're often elevated in the bloodstream when there is a bacterial infection brewing. So if you ever have been evaluated for fever in the ER or your doctor's office, they oftentimes will check a white blood cell count. But what they really want to know is, are the neutrophils high? Because if they are high, it gives us an idea that, yeah, that fever is generated by infection, and that's usually bacterial. There is an immune deficiency diagnosis that's categorized by very lazy neutrophils. So the neutrophils can't get to where they're needed to clean up the mess. So they stay sequestered. They don't get activated when the immune system, the general's like march, and nobody's marching. This is a primary immune deficiency disease called chronic granulomatous disease. But that's a disease of the neutrophils. Antibody deficiency is the most common primary immune deficiency. And we're going to talk about antibodies for a while, because we can look at antibodies once we know that the foundation of the immune system, the lymphocytes, are there, the neutrophils are there. We can say, okay, let's look at antibodies. There's 4 main types of antibodies. All of them are born and mature from a lymphocyte. And all of them have different functions. So let's talk about these now, kind of in order of importance in my brain. So IgG, hold on a second, I can't see my slides. Oh, there we go. Now I can. Okay. So IgG is the most prevalent antibody in our bloodstream. It is the foot soldier of our immune army. It's our first line of defense for pathogens. And by pathogens, I mean viruses, bacteria, fungi, virons, all of those prions. This is the first line of defense of things we've seen before. So whether you've been sick with it, or you were vaccinated against it, you have a soldier waiting on your front lines to protect you from it. This IgG has memory, and it's infection or vaccination triggered. So there's 4 subclasses of IgG, and I find it helpful to look at all 4 subclasses. So if somebody has a normal IgG, you can look at the subclasses, and there may be a complete absence of one of the subclasses. And that would help us sort of narrow in on a cause of recurrent infection, a cause to explain that history we got earlier. The second most important antibody, I can advance my slide now, is IgM. So IgM is the Air Force. So IgG, the foot soldier, IgM is the Air Force. So IgM is the first antibody to respond to an infection. It flies out to scout about what's happening in the body. So let's use an example. I woke up with a fever, right? A fever, I got chills, I got body aches, I got a headache. Your immune system recognizes that, and it activates your lymphocytes and sends out IgM to figure out what's making you sick today, right now. And it drops the bomb on them, learns about what is making you sick. So, oh, this is a virus. It's got a protein on the capsule and it sticks. And then the rest of the cleanup crew comes around to get you better, right? But you had to get sick to get a response. Once that response happens, so this is something I've never seen before. Let's say influenza was making me sick. So influenza-specific IgM is created to bond to that virus, clean up the mess, and then you get better. And IgM, after learning the characteristics of the virus, doesn't hang around long, but before it leaves, about 6 weeks, before it leaves, it goes to the front line and it teaches those soldiers how to be on the lookout for it. So it basically cleaves the end of the portion of the antibody and switches to IgG. So now your IgM is gone and you have IgG on the front line. And that is called immunity. You got sick, you got better, you got protection. So that's the role of IgM. IgA is the third most important antibody, and IgA is the Coast Guard. So nobody ever said we were sending the Coast Guard in to fight a big battle, right? The Coast Guard really stays close to home and protects our ports of entry, right? Keeps out the riffraff. This is what IgA does. IgA is a secretory antibody. And while it is produced by the lymphocytes in the blood, just like the others, it is secreted on our surfaces so that it can protect our ports of entry. So it's in our saliva, it's in our snot, it's in our tears. It covers our whole gastro tract. Women have it in their vagina. We secrete it in breast milk and pass it to our babies to protect their GI tract as well. But, you know, not very specific. So people can live long, healthy lives with no IgA. IgA is just not a very potent antibody. Yes, those people with IgA deficiency may have more sinus infections. They may get more gastroenteritis, but they really are not getting the same pattern of infections that somebody with an IgG defect would get. So this is the fourth antibody. And this guy, this gentleman is a Marine. So IgE is produced, again, from the lymphocyte when your immune system overreacts or reacts to an allergen. Specifically, we think about it as an overreactor. These antibodies travel to mast cells and release chemicals that are causative of an allergic reaction. So a mast cell is a holding tank for things like histamine and leukotriene and interleukins. And when that mast cell gets covered in IgE, it ruptures. And when it ruptures, it releases all of these inflammatory chemicals into the body. And what do we get? We get snotty nose and itchy eyes, and maybe we get wheezy because we have asthma, or we get hives because our skin is reacting. But IgE is often behind the start of that reaction. So having a deficiency in IgE is not that important. Having too much IgE is really what stirs the pot. But here's the thing. In IgE, if we want something done, if we want to start something, we send in the Marines, right? So we wanted to find bin Laden, and they sent in the Marines because they're real good at stirring up trouble. And without stirring up trouble, without causing that reaction, your immune system may not get interested in something. So we think that IgE seems to be protective against invading parasites. We know for a fact that people who have parasitic infections have more IgE. Get rid of the parasite, IgE goes down. So we're learning a little bit more about the immune function, not just the allergic function, but the immune function of IgE. So there's more to the story. So those are the four main types of antibodies. So if you come into a doctor's office, you have a history of recurrent pneumonia, you've been hospitalized for infection, and they do blood counts and they're perfect. And they look at your antibody levels and they're totally under that bell-shaped curve and you're in the 90th percentile, they say, you are normal. That is not the whole story. Because if you wanted to fight a war and you sent in only untrained soldiers, you're going to lose. So you've got to figure out a way to train the soldiers or to know that they are trained. So we need to do a functional assessment. So this is my nightmare. I literally have a recurring nightmare of having to climb the rope in gym class. These guys are having to get over this wall. This is a part of basic training for our foot soldiers in our army, because that's one way that we know that they are physically fit and should be able to fight a battle. In the immune system, functional assessment tells us if all antibody numbers are normal, that there may still be a problem. Just because antibody levels are low though, like you may have an IgG that's outside the normal, but the function's really good and you have like a green beret, right? Like this highly trained antibody that does a great job. You may not be at risk for infection, but you may have normal soldiers and none of them can fight. And so this is how we do a functional assessment. It gives us clues about the actual abilities of the antibody. And we do this through antibody titers. And you've probably all heard the word titer, but titer just means dilutions until we get a reaction. So an antibody titer is a blood test that determines the level of antibodies in the blood to specific things. This test is carried out to investigate if there are immune reactions triggered by invaders in the body. Sometimes we look at things that are almost exclusively put there by vaccines. Diphtheria and tetanus are two great examples. So, I mean, in developed world, we don't see a ton of diphtheria. Diphtheria still exists, right? But, you know, it's just a sore throat for most people, and they get an antibiotic and they get better. Tetanus is still in the environment, and we protect everybody against diphtheria and tetanus because it's a real disease and it's a real crippling disease. So we start giving our babies diphtheria and tetanus shots along with pertussis when they are 2 months old. So by the time you go to kindergarten, you've had 5. And then you get another one at middle school. And then every 10 years for the rest of your life, your primary care doctor is always saying, when was your last tetanus shot? Or you get a cut, you go to the ER and they're like, we got to give you a tetanus shot. Those antibodies can be measured. And they give us an idea of how you do making a response to an antigen, to a bacteria in this case, that was given to you by vaccine. And so that is something that we use diagnostically to help answer some questions about how important are our first findings. Pneumococcus, however, is an interesting pathogen because it's a bacteria. And by the time we're 30, most of us have seen at least half of the serotypes of pneumococcus. That's the general sort of thinking and rule of thumb, that an adult, even without ever having had a vaccine, should have protection against pneumococcus. And if you don't, that might be unusual. That might be something worth checking out. So we're going to talk about vaccine challenges in a minute, but pneumococcus is one of the ones that's easy to do a vaccine challenge because when we're young adults, like me, for instance, you've never had a pneumococcal vaccine. So any protection I have is naturally acquired. Chickenpox is another great one to take a look at because people of my age typically had chickenpox as a child. And so we can measure that immunity. And most women know their chickenpox status because if they've had babies, they've had their chickenpox checked. But that's another good way, sort of a good marker of a conversion of a naturally acquired infection into protection. The problem comes in assessing immune function in somebody who has never been vaccinated or refuses to get vaccinated, because we have to be able to demonstrate not only, I mean, what if I don't have any pneumococcal antibodies? I'm over 30 and I get a vaccine and I have all of them, right? Maybe I just dodged a bunch of bullets in my life. We don't know. So the vaccine challenge really helps drill down to what is real. My slides are slow to react. Hold on. Oops, sorry, I went too far. Okay, so the vaccine challenges. So let's talk about those for a second. So a vaccine challenge is a way that we diagnostically learn about how your body deals with infections, or deals with exposures, I should say. So the vaccine challenge boosts your immunity with a vaccine. So we do a baseline level. So let's use pneumococcus as an example, since I started that already. So I go into my doctor with recurrent infection. He draws all my functional assessment, and he's like, you're older than 30, barely, but older than 30. You have no antibodies to pneumococcus. I think we should give you a vaccine challenge. So they give me a pneumococcal vaccine. The pneumococcal vaccine that we most often give in this circumstance is something called the Pneumovax. It's an old-fashioned vaccine. It's been around for a very long time, but it's a real pure single antigen vaccine. So give me the pneumococcal vaccine. There are 23 different types of pneumococcus in that vaccine. So I know going into it, I didn't have any. I get the vaccine 6 weeks later, I go in and they draw my blood again. And then they look and see how many did I convert to protection. It takes about 4 to 6 weeks for my immune system to respond. Remember, going back, Air Force comes out, identifies what it sees, goes to the front line, converts it to protection. IgG is the memory. Then my doctor measures my IgG to pneumococcus and finds, oh, she did great. She made 70% of the vaccine into protection. That is a successful vaccine challenge, and that is likely not the cause of my recurrent infection. But a failure to respond is important. If I go in and they draw my labs and I only responded to 5 of the 23 different types of pneumococcus, that is important. The second important part is rechecking it. Had the vaccine, had a great response. What happens down the road? If I come back in 6 months, am I still going to have a good response? What about next year? Am I still going to remember those? A normal, healthy immune system should be able to retain that memory, that protection for extended periods of time. And with the pneumococcal vaccine, it's at least 5 years of sustained response. So failure to recognize a new antigen is an important clue, but failure to hold on to it is also an important clue. But more important is that if you have a good response, it's super encouraging. It may be one of the things that helps us move forward away from an immune deficiency diagnosis. Okay, so that's everything I know about antibodies. Not really, but I think it's a really good sort of story about how the antibodies work in our body, but they're not the only thing that fights infections. I want to talk about lymphocytes and memorize this chart, because in order for you to move forward in the forums, you have to have a test on this. No, I'm just kidding. This is super complicated. This is the maturation sequence of a white blood cell. So I didn't put the whole thing on here because I don't want you to know about it, but it talks about how the white blood cell is born in the bone marrow, but matures in the thymus, or in adults, oftentimes in the lymph nodes, armpits, groin, abdomen, chest, and then becomes a type of a lymphocyte that can be regulatory or suppressing. We have a method to measure this maturation process of this lymphocyte, of this white cell, in a lab technique called flow cytometry. I put it in this picture because it's really interesting to see how this is actually how the reports are printed out. They flow them onto a graph so you can see where cells are in their maturity. And this helps sort out the different types of lymphocytes: T cells, B cells, and natural killer cells. Now, in full disclosure, I don't do this workup with every new patient that comes in. Sometimes I wait until I do what we talked about previously in order to dive a little deeper when I find a defect. So if I find somebody who has a low IgG, poor IgG function, and recurrent infections, I would then, on a second pass, look at flow cytometry. It's not always useful, and it's real expensive, but it's not that's not the only thing. It's just not useful because it gives us a lot of data that we don't know how to process always. I want to talk about the T cell first. So the T cell, or the T lymphocyte, is the stop and go cell in our body. Remember when I said the T cell is the general, right? So the T cell is the guy that's telling everybody else what to do. So T cells are lymphocytes that are directing the whole response. They help the B cells function properly. So the B cell, we're going to talk about that next, is the cell that produces antibody, but the T cell is the director of that cell. So the T cell tells the B cell what to do. There are different types of subsets of T cells that first became popular in sort of common language when HIV was discovered, because we learned very quickly that people who had AIDS caused by HIV had a diminished population of helper cells. Helper cells are CD4 positive cells. The CD4 cells are the go. So they're the green in this light. They're the ones that tell everybody to get going, get working, nose to the grindstone. Suppressor cells, the CD8 cells, are the reds. They're the stop. They're the ones that tell the immune system to back off, like, whoa, 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 whoa. Y'all getting too worked up. They are a good stop measure so that we don't continually fire off new immune cells that can create damage in our body in something called autoimmune or autoinflammatory disease. There are cytotoxic T cells, and these are T cells that can kill germs on their own. These are just like snipers out there that know exactly what they're looking for. And then there are regulatory T cells that are, again, sort of the stop mechanism, like making sure that everybody is not going overboard in their reaction. T lymphocytes are important because of TREX. So TREX is a newborn screen that we do in all 50 states of the United States that is an early identification for severe combined immune deficiency syndrome. So TREX, they take a little blood spot from when they poke the baby's heel, they take a little punch out of that, and TREX help us to identify that T cells are present. And T cells, T lymphocytes, are a very important part of the immune system and are diagnostic. The absence of them is diagnostic in important immune deficiencies like SCID. Every time I move my bar around, I end up not being able to move my slides. Okay, B cell. This is where antibodies are born. The B cell is the factory that produces antibodies. So we talked about the 4 antibodies, right? G, M, A, E. They are born in the B lymphocyte factory. So these lymphocytes are told what to do by the T cell. So they're told what to produce. And there are subsets of B cells that help us to, when we sort them out, helps us to identify where immune defects lie. Now, this is science that has improved greatly since my last talk on this in 2018. We now have easy tests available to almost every immune deficiency care center that can help identify populations of memory B cells, naive B cells, sometimes even the reactive components that lead to things like lupus. Using this test is most useful after we've already diagnosed a primary immunodeficiency disease to help us pinpoint the defect. And once we've pinpointed the defect, we can start giving information like prognostics, treatment options, genetics, all of that. The third lymphocyte, so I said T cells, generals, B cells, factory, and the T cells. The T cells can kill germs directly also. The natural killer cells can kill germs directly too. Often they're associated with a vulnerability to different kinds of viral infections, and most notably herpes infections. And herpes isn't herpes. Herpes is a family of viruses like chickenpox, Epstein-Barr, yes, herpes, but they're all from the same family and can be controlled by natural killer cells. They have a strong function against physiologic stress, like tumor cells. When we all get tumor cells, right? But our immune system takes care of them. And that may be a really important function of the natural killer cell. There is a test For NK cell function, so we can count the NK cells in the flow cytometry I identified before. There are labs that do NK cell function, but it's a very expensive test, and it's not widely used. It's not widely available to your neighborhood immunologist. So complement is something, I love this picture. Complement is a family of proteins that have multiple functions in the immune response. In the immune system, they are the agent of opsonization. It's a great word, but what does it mean? The complement makes a bug look appetizing. Now, if you had a grasshopper sitting on a plate, pretty sure you wouldn't reach in and grab a bite. But if you dip that grasshopper in chocolate, you may be tempted to take a bite. You may not even know what it is and take a bite of it. And that's what complement can do to some of the bacteria and viruses that enter our systems. They make pathogens look more appetizing. They're like the sticky part of the Velcro, right? They help antibodies get interested in pathogens, and they stimulate a better antibody response. The test that we will most often see for assessing complement levels in the blood is a CH50. But there are individual complement levels like C3 and C4 that are important. In some forms of angioedema, C1, C2, C1 esterase. There's lots of different parts of complement, but the whole system of complement just makes our immune system run better. Of course, I moved my bar again. There we go. Okay. I'm not sure how I'm doing on time. Colleen, can you give me a thumbs up or a thumbs down how I'm doing on time?
You're doing fine.
Okay, good. I want to talk about genetics. Genetics in itself could be an entire talk. And so I kind of pared this down so that we can, sort of have enough time to digest here. Primary immunodeficiency diseases are caused by many different genetic mutations. At least 456 of them have been identified, and there are hundreds more that have not been identified. Testing for a known gene mutation can help us, your healthcare providers, confirm a diagnosis, which then in turn can help us direct treatment and prognosticate. So say people who have this genetic mutation go on to develop X or Y. So genetics can be a really helpful thing, but they can also be a real confusing trip down a rabbit hole. So I want to try and pare down what's important, and to kind of, I'm not going to discuss how they do all the tests, but I want to talk about what the different types of tests are. So first and foremost is something called the microarray testing. And this is a test that we do that looks for major chromosomal changes. We use a microarray to identify things like trisomy 21, which is Down syndrome, or trisomy 18, or any of the trisomies for that matter, or big chunks of DNA that are missing. There's a immunologic disorder that's associated with a syndrome called DeGeorge syndrome. And DeGeorge syndrome is easily picked up on a microarray because there's a major chromosomal change in those diseases. But that's not true for people with common variable immune deficiency syndrome, or severe combined immune deficiency syndrome, or CGD, or any of those others. At that point, we as prescribers and diagnosticians have to order what's called a targeted gene study, or a gene panel. So this is where we take all of that knowledge that we learned from our first workup, maybe our second pass workup, and then we say, people who have antibody deficiency with low memory B cells often have, this gene mutation, and we can order that gene mutation and see. There are labs across the country that are getting cheaper all the time. Five years ago, you used to have to get a patient a consult with a genetic counselor in order to order any of these panels, because they were thousands of dollars, like $5,000 to do sequencing, even when you had a target. So nowadays, there are commercial labs available that people can do on their own to target. So 405 genes, I think now in the Invitae panel. I'm not sure, I have to go back and look. It changes all the time. But Invitae is one lab that does targeted gene studies. And we don't really even have to justify it. We can say this is a patient with family history or recurrent infection and antibody deficiency. And these tests are getting cheaper all the time. Then when that comes back totally normal, we can do what's called whole exome sequencing. So whole exome sequencing is the next step when we don't find anything on the targeted gene analysis. But the problem with whole exome sequencing is it gives us too much information. So we all have different genetic differences. That's what makes us unique. And sometimes those genetic differences don't mean anything when it comes to the reason that you're ill or the reason that you're seeing an immunologist. So we call these things non-pathogenic mutations. So, and it may be something that you have, it may be something that your mom has, it may be something that her mom had. But we don't know all the time what's important and what's not. But when we do whole exome sequencing, that data and the phenotype or the situation of the patient is put together in a database. And then that may help us as diagnosticians over time say, oh, you know, both of these patients had low antibody, recurrent infection, and color blindness. And we can, over time, we can make a database that all had the same genetic mutation. And boom, what we have done is we have led to the discovery of a new genetic mutation associated with a finding. Now, I'm just making that up, but that's how these databases work. And that's when gene changes are of unknown significance. So I've done, gosh, I mean, I'm real hesitant to do whole exome sequencing because of how much head scratching it causes. I spend a lot of time going, really? Do we need to bring in her mom or sister or her kids? But over time, as we discover more of these variations of undetermined significance or unknown significance, we are going to discover new genetic mutations that are important. So that was a lot. I feel like I went through genetics really quick because I think that a genetics conversation must be really tailored to your specific findings. And so, you know, throwing out the name Invitae as a whole panel of genetics is risky because I don't want y'all run into your immunologist saying, you know, this woman said we should do it in Invitae panel. No, I didn't say that. I said it exists. It doesn't necessarily help us direct the next step, but it may help us from a family history standpoint predict future problems in your bloodline. So, Kathy, I guess this is where I'm turning it back to you. I'm not going anywhere, people. So I'm gonna sit right here, I'm gonna stop sharing and let Kathy share.
Okay. Well, Chris, a huge thank you. Thank you to you for making a presentation that could be very complicated, understandable. And thank you for just sharing this wonderful information with us. And at this time, I would like to introduce and invite my colleague, Colleen Brock, Manager of Medical Programs at the Immune Deficiency Foundation, to take the lead here on the Q&A session. So I will now turn this over to you, Colleen, and hand it back to Chris.
All right. Hello, everybody. I have been attempting to answer some questions as we've gone, and I have a slew of them over to my side. So hopefully we can get to as many as possible this evening. You guys have some great questions. I will go ahead and make 2 announcements. If for some reason we do not, and I don't foresee that we're going to be able to answer all of them, we do not get to your question and you would like to have it answered, I encourage you to go to the IDF website, click on the Ask IDF tab and ask your question, and we will see that you receive an answer. Excuse me, we are also not going to be answering any COVID questions tonight. We had a forum 2 weeks ago. Again, you can submit any question you would like about COVID through Ask IDF, or you can go to the website and view the entire forum that we had, which addresses everything you could possibly think of. So let's go ahead, Chris, and start. I've kind of broken it down into categories. Let's just start with some general testing questions. And you kind of went through a lot of it, but there's certain ones that people aren't quite sure about. One of them is age. And how does testing, or how is testing affected in the realm of age from infancy through elderly? Does it change? Does it vary? Are there different ways of doing things?
So the testing itself and the process for proceeding through the testing doesn't really change. The normal ranges change. There is a normal range for each age group, and that's where that normal distribution curve discussion comes in. So an infant is born with no IgG. So it is perfectly normal for a 6-month-old infant to come into the office with an IgG level of 200. That would be in the normal range. But if a 30-year-old man came in with an IgG level of 200, that would be considered profoundly deficient. And so I think that normal distribution curve moves through the ages. And then again, there's a condition called immune senescence. And that's when we get old. Senescence is just a really fancy name for old. So when we get old, our immune system does start to degrade. And so normal ranges then back off again in the elderly time period. And so age has a lot to do with normal ranges, but doesn't necessarily have anything to do with how we progress across the diagnostic spectrum. Infants have to be vaccinated in order to have a functional assessment, because if you have a 1-year-old who comes in with recurrent infections and you want to check their functional antibody and they've not received any of their primary series of vaccines, you have nothing to look at. They haven't lived in our world long enough. And so you will hear a speech from your immunologist about starting vaccinations in order for us to sort of wrap up that functional assessment. So those are some of the age-related considerations from young to old. But I think progressing across the spectrum, like I laid it out from the foundation up through the troops, is the same for all ages. You're on mute. You're on mute.
Sorry, thought I clicked it. I love that button. So let's talk about subclasses. Mm-hmm. Subclasses are a very interesting.
Controversial. Mm-hmm.
Yeah. Mm-hmm. Lots of controversy and lots of confusion and lots of questions. So some of the questions, can you please explain them? You know, what exactly do each of them mean? Do each of them hold the same value? Why do some doctors look at them? Why do some doctors not care at all what they say? Is it possible that one of them being low affects your treatments? Mm-hmm. I have another one that just popped up here. I just lost it. Somebody else just asked another one about subclasses. Oh, here. What if you have your subclasses are normal? You know, what So just sort of touch on subclasses to kind of better.
I'm not surprised that it's a big question. I'm not surprised that it's a question because there is quite a bit of controversy over subclasses. Some immunologists don't even look at any of the subclasses. You either have a normal IgG or it's not normal. I've gotten burned by that a couple of times. And I'll tell you a story about it, and then I'll tell you about, to answer the other parts of that question, Colleen. But so I had a 68-year-old woman come in. She's an RN. She came in with recurrent pneumococcal pneumonia. She had been hospitalized 4 times with pneumococcal sepsis, started in her lungs. Not a smoker. She's a nurse. She had been to an immunologist who had looked at her IgG-AM, and they were all normal, and said, there's nothing wrong with you. I think you're a closet smoker. And so after one of her hospital stays where she spent 2 weeks on a ventilator for pneumococcal pneumonia, she came to us and I did her subclasses. And she had an IgG total of 2,350, which is on the high end of normal, probably above what would be considered the normal range for her age at 68. She had all of it in IgG subclass 1. So she had no IgG subclass 2, 3, or 4. And so what had looked like a normal IgG antibody level turned out to be malignant melanoma. Multiple myeloma. She had multiple myeloma and had a malignant clone of IgG that was growing all in that one subclass. And so she had common variable immune deficiency syndrome. She had low to absent memory B cells. She did not have normal maturation through the entire B cell process. And she ended up on immunoglobulin and did famously. She also is getting treated for her myeloma. And so that clone of cells is coming down. And so I think that's really important identifier that if you don't look at subclasses, you could be missing something. Now, IgG subclass is 4 types. Subclass 1 and subclass 3 over the years have been hypothesized to work against the pathogens that have more of a protein trigger on the surface. And then subclass 2 and 4 are said to work together against those antigens that have a carbohydrate on the surface. And that is sort of a generally accepted philosophy of IgG subclasses. IgG subclass 4 is not a very important infection fighter. So you can have an absent IgG subclass 4 and not get me too excited. In fact, most normal ranges for IgG subclass 4, 1 is normal. So if you have an absent IgG subclass 4 and no other findings, I'm not real, serious about a primary immunodeficiency diagnosis. Now, I'm not saying we'd rule it out because of course you'd have to go through that whole functional assessment of antibody and make sure that all of those parts are actually working, because numbers are just part of it. But so high or low IgG levels, I check subclasses to see if I can identify where the defect is. If you have a low IgG and it's all pretty normally distributed through the 4 subclasses, and your functional assessment is normal or good even, then I don't worry about you. Then I mean, I'm not going to take my eye off you, but I won't worry about you, and you wouldn't probably end up on immunoglobulin. So IgG subclass examination just simply augments the IgG level. But I think the problem becomes you can miss important things if you're not looking at the subclasses in that one example. Does that help? I mean, I maybe didn't address all of the subclass issues. Oh, I know the other question you had, Colleen. You asked, do subclasses sometimes impact your treatment?
Correct.
Yeah, so that is actually something that I do sometimes sink my teeth into. So if I have a patient with hypogammaglobulinemia who's receiving immunoglobulin therapy, either IV or sub-Q, I will, every 6 months, look at their IgG and IgG subclasses. And I do that because IgG subclass 3 is the subclass that we metabolize the fastest. And so if at the end of your treatment regimen, so let's say you're every 4 weeks immunoglobulin, at the end of 4 weeks, if your IgG subclass is dipping down below normal, you may need a dose increase, or we may need to shorten your interval to a 3-week interval to make sure that we keep that one within the normal range. Some patients, and I have handfuls of them, never get their IgG subclass in the normal range with immunoglobulin replacement until we go to sub-Q. Once we go to sub-Q and we are giving them a weekly dose or even a daily dose, sometimes at that point we can get the IgG subclass 3 well replaced. But even more important than that is making sure that from a replacement standpoint, yes, we do look at IgG subclass 3, but we also look and see how you're doing. Like, how are you doing? Are you getting a ton of infections? Are you feeling like crap all the time? Are you missing a bunch of work in school? And if the answer to that is no, and your IgG subclass is low, I might not change anything. I might just watch you.
Who is the best physician to start this process? Some think you have to go immediately to the immunologist if you are suspicious, but as we know, that's not always the case.
The problem with answering that question, though, is that you guys are all across the country. And if you're on the East Coast and you have, 10 immunologists within 100 miles of you, you could go to make an appointment with a doctor who specializes in primary immunodeficiency. But if you're in Minnesota and your primary care doctor says, I really think you could have something wrong with your immune system, they can certainly start this process. Like kind of in that algorithm we talked about, start with blood counts, then go to antibody levels, and then on to functional testing. So your primary care can start it, right? At least rule out some of the bad and scary things. Allergy doctors have certification in immunology. So not all of them want to do immunology. A lot of them want to refer to immunology, pediatrics usually. But all allergists have a background in immunology. So if you are in a state where your immunology clinics are few and far between, like Minnesota, you can start a workup and get quite a ways through the workup with an allergist. And then once the allergist gets in over their head, they will refer on as appropriate. They know when to refer. Infectious disease also does it. I should probably say that because I'm in infectious disease. So infectious disease providers oftentimes will do a preliminary immune workup as well. Not a lot of infectious disease doctors want to manage immune deficiency disease. I do. My group does. But infectious disease would be another place where your infection concerns can be evaluated, like we said from the very beginning, types of infections, frequency of infections, types of treatments it takes to eradicate infections can all be an infectious disease visit as well.
Thank you very much. Let's go talk about B cells. So can you explain the significance of B cell testing? And what does no memory B cells mean? And, anything else that you can kind of tap into?
I'll dive a little deeper.
Yeah, there's one that, is there a blood test to check for defective B cells when the levels might be normal? But just a little deeper dive into B cells.
So B cells are really exciting in today's healthcare because a lot of the therapies that are out there for other chronic diseases mess with the B cell. And so the B cell is a real maligned offender in things like multiple sclerosis and rheumatoid arthritis. So a lot of times physicians and other specialties will use medicine to wipe out the B cell. So that they can stop having autoimmune or autoinflammatory disorders. However, when you stop giving that medication, there's a chance that when your B cells come back, they don't come back in an orderly fashion. And so the B cell has gotten a lot of attention in testing so that we now know a lot about how that B cell is born, how it comes back after it's been wiped out. And the memory B cell is the one that is responsible for converting an IgM response, remember the Air Force, into an IgG response, remember the foot soldier. So without a memory B cell, you're not going to make IgG that is functional. Now you may have normal IgG levels, and this is one of the pitfalls. I said, just because you're normal doesn't mean you have good function. So a person with normal IgG levels and no B cells typically has very poor immune function, meaning that they don't take an exposure and convert it to protection. So the memory B cell does all of that converting, and then it does all of that sustaining. And so you may not, you may get, I'm going to say COVID, and I know Kathy, you're going to slap me for this, but you may get COVID, and you may get an antibody response, and you may promptly lose it if your memory B cell is defunct, right? The same is true for naive B cells. So you have to have naive B cells in order to make a new antibody. And so if you are on anti-B cell therapy, I'm just going to say the name of a couple of drugs, Roxience, rituximab, Ocrevus, or ocrelizumab. Those medications eradicate the B cell. And so if you were to get a new vaccine during that time, you may not make a good response because you don't have a B cell. You don't have a naive B cell, you don't have a memory B cell, you don't have a B cell population to work with. So B cells are very important. They are important in both good immunity and bad immunity. And so we are, and you can look at the IDF's page about secondary immune deficiencies, but there are secondary immune deficiencies that are caused by the therapies that we're using to stomp out some of the auto-inflammatory disease or autoreactive diseases in our world. But I mean, B cell science is expanding very rapidly. It's a very interesting topic. We could probably do an entire forum on just the B cell and the evolution of the science. But I think that kind of, does that answer the question? I think it does.
Well, it's constantly evolving.
Yeah.
But here's a question that came in. Please speak to the 15, 16-year-old, very low B cell for a 15-year-old, mildly low if she's 16. How is that synthesized?
It's that normal distribution curve. It all goes back to my very first slide on our statistics review, right? So they take these chunks of maturity. So the pediatric timeframe typically goes until about age 15, and then you become an adult at 16, and then you get adult ranges 16 through usually 42, 45, and then you have the seniors above that. Figure that. Okay. But but again, those cutoffs you have to be processing those in context of what you are testing for. So yeah, you can have low B cells, but what's the end output, right? Are you seeing low function? Are you seeing low numbers? Are you seeing weird infections or nuisance types infections? It's not one thing that makes the diagnosis. Now, I know people say that if you have, IgG and IgM low, you automatically have CVID, and that is diagnostically accurate, but it doesn't help us boil it down to what you actually have to be treated for. I have patients who have very low IgG, very low IgM, and don't receive immunoglobulin because their function is great.
Right. So what is the test for memory and naive B cells?
The B cell phenotype. It's another form of flow cytometry that basically just looks at the maturation process of the B cell in a blood draw. It's just a blood draw. And just like we use markers to identify what's a B cell, T cell, and natural killer cell, we have markers that mark, what's a CD127, what's what's the memory B cell, what's the switched class memory B cell, what's the non-switched class memory B cell. There are 40 B cell markers, I think, right now. I'd have to look at a B cell phenotype to know for sure, because every one I get has a new one added, basically. The science is expanding rapidly.
And if you're on IgG replacement therapy and you're doing the testing, is your therapy affect the level and function of your B cells and T cells?
Nope. No, it doesn't. Your B cell is independent of antibody, but that does actually bring up a really important comment that I probably didn't put in my slide that I should have. And that is, if you are on immunoglobulin therapy, none of these tests are interpreted the same, except for the flow cytometry. So your lymphocyte studies and your B cell studies are unchanged by the outside immunoglobulin, but your antibody levels are changed. IgG, 95% of your immunoglobulin is IgG. So your IgG levels are not all yours, and the functional component of IgG is not yours. It's donated. And so you can't use a functional assessment if you're already on therapy to determine your responsiveness to vaccines. But B cells, T cells, NK cells, helpers, suppressor, memory, naive, that's all you when we do flow cytometry.
Okay, I'm going to throw some quick ones at you, and then we're going to talk about T cells. So what is the value of regularly monitoring a SED rate or an ACE level?
An ACE level? Oh,
yeah.
So SED rate and C-reactive protein are two markers of inflammation. And so I don't regularly monitor SED rate and C-reactive protein unless I have a patient who has concurrent reactive immune disease like lupus or rheumatoid arthritis, because those cytokines, they're called cytokines, inflammatory chemicals or inflammatory proteins in the body. Those sometimes are markers of active disease. ACE is a marker of a specific disease called sarcoidosis. And so an ACE is a very specific test that we use for monitoring disease activity in something like lupus or sarcoidosis.
Righty. Sorry, I just lost my, there's a lot of questions about CD4, CD8s, CD27s, 38s. What, not going into specifics, but what is the generalization of all of those kind of components?
Well, so CD4, CD8 is a T cell marker. So that's CD4 is a helper cell, CD8 is a suppressor cell. So that looks at the T cell and sort of the distribution of the type. You should either be a helper or a suppressor. Most of your T cells are one or the other. The other markers are B cell markers. CD16 plus CD56 is a natural killer cell marker. So all of those CD, those are all parts of the lymphocyte that are all fleshed out in that flow cytometry. I was going to say flowed out because that's truly what they do. They flow out into their maturation sequence. Those markers are added to your blood, and that's how and they attach. And then once they attach, they light up. And so if you give a marker of CD4 attaches to a cell and we can light it up, we know that that cell it attached to is a T helper cell. So all of those numbers are all in that flow cytometry to look at the lymphocyte and the distributed lifespan of the lymphocyte.
Okay. What do you know about elevated NK cells in people with CVID?
I know that it exists. I don't know that it is detrimental. And I think that is also, NK science is also evolving, but I don't, elevated NK cells at this point in my knowledge don't concern me. It's something that you go, look at that marker's high, but why? And what's the consequence of it? If it were grossly elevated, there are some T cell lymphomas. There are some lymphomas that can cause NK cells to become high, but that is usually an astronomical elevation.
And when somebody is going through their thorough workup, a lot of these different components the NK cells, the memory B cells, all of the CDs, everything. Those are all part of the routine deeper dive, correct?
No, not the routine. I wouldn't say, no allergist is going to.
No. But when the immunologist does the deep dive.
Yeah, right. That's more of a fine tuning of a diagnosis, right? So this is after we've already settled on a diagnosis that we can dive a little bit deeper into the B cell and say, okay, here's where the defect lies. And we see this in CVID. It's a lack of the class switched memory B cell. And then we can say, so that's sometimes associated with this particular genetic defect. And we could do a targeted gene test to say, hey, you have this gene.
So when physicians are doing those deeper dives, you're going to be told the functions of your T cells. And there's a lot of talk.
Numbers, not functions.
Sorry, correct.
Yeah.
But now with COVID, there's a lot of emphasis on T cells where it was all antibodies and B cells, and people are starting to wonder, were my T cells looked at? Do I know if they work? And talking to their immunologist is the best thing to do.
Yeah, for sure. And I oftentimes, this is not a test I repeat. I mean, this is oftentimes a one and done. Like when I meet a patient for the first time and I'm trying to work on a diagnosis, I'm chipping my way into this patient's, diagnosis through history, through labs, through function, through flow cytometry. I typically do it once. And then once I've done it, then I feel like I can say, okay, I feel confident with my diagnosis. I feel confident with my treatment. Unless something hematologically happens, like a cancer, like a lymphoma, a bone marrow transplant, a leukemia, or some other factor that wipes out the bone marrow, I don't go back and look at it again.
Okay. Diagnostic testing in a little more depth. The recommended tests to follow for hyper IgE, other than, especially if your immunoglobulins are normal, how does one determine dominant or recessive hyper IgE syndrome? So if your IgE is high and everything else is normal, how would a physician?
There's actually very well-known syndromes associated with the elevated IgE syndromes. And there are only a few that qualify as hyper IgE syndromes. And those are usually the STAT3 gene mutation. So it's a genetic diagnosis. And those genes can be done as a part of a panel or as a targeted panel, which usually includes the STAT genes and the DOC8. So having elevated IgE as an only finding with none of the features of Job's syndrome, which is a STAT gene mutation, STAT3, would be things like loculated infections of the skin, deep boils, those kinds of things, osteomyelitis, bone infections, pneumonias with atypical organisms. If you don't have any of those features, and then there's some actual physical features like a broad, flat nose, funny hair, like different textured hair, then you don't qualify as having hyper IgE syndromes that are identified genetically. The hyper IgE syndromes are an immune deficiency, often treated with immunoglobulin because of functional defects and impairments in how the B cell operates. So again, we get back to B cell function, right? But other things can cause IgE to be elevated, including food allergies, food sensitivities, atopic dermatitis. That's one of those which came first, the IgE or the skin. And so it's hyper IgE syndromes are one of the syndromes right now that are typically diagnosed through genetics, not just lab findings.
Okay. What is the test used to test neutrophil function in CGD, chronic granulomatosis disease?
What test is used?
Yeah, to test, okay. How do you test the neutrophil function in somebody with CGD?
Good question, actually, because I kind of breezed over that whole neutrophil section, right? So CGD is a disease of neutrophil migration. So neutrophils, while they're born in the bone marrow, they reside most of the time in the tissues and along the lining of our blood vessels. They are activated when they are needed, and they get to the site of infection by migration. They are called there, and thus they go. So there is a test called DHR, and dihydrorhodamine, if you want to know what DHR stands for. Dihydrorhodamine is a marker of neutrophil migration. Super easy test to do. In fact, it's free for most patients through the Actimmune. Has a testing foundation, and Actimmune, and I think Actimmune will even do the genetics for free now. But it's an easy test. It has nothing to do with anything that I've even talked to you about tonight, other than looking at neutrophil numbers. Neutrophil numbers are always high or normal in patients with CGD. They just don't get to where they need to be. So in that particular case, it's a really important history taking that leads you down the path to looking at dihydrorhodamine in these patients. But yeah, it's a pretty easy test to do.
So if you have an immune disorder and you have low neutrophils, is that cause for concern? And what might that be?
Yeah, for sure. Absolutely. Low neutrophils are always cause for concern. It's called neutropenia, and it can be caused from lots of different sources. It can be congenital. It can be autoimmune, meaning that your own immune system attacks neutrophils, or it can be caused by some medications. And some infections can cause neutrophils to dip rather than to soar. So usually potent viral infections will cause lymphocytes to increase and neutrophils decrease. So yes, low neutrophils are always a cause for concern, but there's degrees of low, right? My threshold for concern is usually 1,000. So if your absolute neutrophil count is above 1,000 and you're not symptomatic, you're not having fever and don't have a wound or a cellulitis, I don't worry so much. But that should always be looked at. If you have low neutrophils, you should always be evaluated.
Couple diagnosis questions before we get into a couple genetic testing. So somebody has written, diagnosis has changed. AGAM, hypogam, CVID. They have no IgA, M, or I assume G. It was a duplicate, a diagnosis. How do you know what it is? And I think there's some confusion as to the change in the criteria for CVID through the years. And also, can you have CVID along with specific antibody, or do you have one or the other?
Specific antibody, I would say, is the lesser of the diagnoses. I think everybody with CVID has specific antibody deficiency, right? I think that's sort of pathognomonic of making the diagnosis. Like, you can't just have low antibodies, you also have to have low function. So specific antibody is a part of CVID. So yes, I would say you have them both together. Gosh, what was the first part of the question, Colleen, that I wanted to speak to?
The difference, the changing of diagnoses.
Oh, okay.
You start with one and then you get another. Is that possible to start out?
Yeah, I have a really great example. So a patient came to me from Florida. He had lived his entire life in Florida until he moved to Minneapolis in his 30s. So he came to me for so that I could prescribe his immunoglobulin, because he had been diagnosed with X-linked agammaglobulinemia when he was 2 years old. So this is basically, if you did the labs, he should have 0 B cells, and 0 antibody. Now, some of these leaky XLAs will make some antibody, but it's usually really sucky antibody. It doesn't do anything. It's real dummies. So this guy comes to me. He'd been on immunoglobulin. He's actually doing great, no problems, right? And so I asked for his medical records from Florida, not 1 time, not 5 times, but probably 15 times I requested his diagnostic labs. And so I have to say, Andrea, if you're still on the call, this speaks to you, because nobody could find this boy's diagnostic labs from 28 years ago, right? So I started over. I said, okay, you're not going to stop your immunoglobulin, you're going to stay on your immunoglobulin, but we're going to do some B cell studies, and we're going to do some genetics, targeted genetics in the BTK sequence, which would diagnose X-linked agammaglobulinemia. Well, guess what? He had B cells. He had, enough to make me think that that was real. And he did not have the mutation in the BTK. So he did not have X-linked agammaglobulinemia. And all of this time, he had been worried that his daughter was going to pass on this gene to her children. And it ends up he really just had CVID that was diagnosed very young. And so our abilities to diagnose change. And as science develops, so do diagnostic criteria. So what started out as agammaglobulinemia for this man ended up being common variable immune deficiency when he was in his 30s, not because the disease changed, but because diagnostic criteria changed and our ability to look deeper into it changed. Does that answer the question? So part of the reason that I do rely on B cell phenotypes and B cell flow cytometry is so that those diagnoses don't change, right? So you don't have agammaglobulinemia if you have B cells. You just have a severe form of common variable immune deficiency. So that's where B cell testing comes in.
Thank you. So let's talk just a little bit. You did a great presentation on genetics and touched on it, and that's a whole entity of itself, but a couple questions. If you are looking at a family history and you have relatives back through generations, or if you have within the family genetic testing, to how important is it? Is it important if it's only going to change maybe the treatment, or like you had said, family planning, things like that? And is it always going to be there? Is it possible? I will tell everybody, in our case, we participated in a study. I have CVID as well to our children. There's no genetic link to any of the three of us, which shocked me.
It does, Colleen,
that we know of right now.
Right. It doesn't mean that's not there. It's just that
right.
We haven't found it. But your contribution of your blood with your code is going to further the science as more of that same genetic, undetermined significant variants are discovered. So yes, I think genetics do play a role. But I think that genetics right now are real helpful in a research, but we're just learning what to do with some of these defects. We're just learning where to look for these defects. And so again, it is evolving. So, not every hypogam patient has to run to their doctor and say, I need genetic testing. I want genetic testing. You certainly have the right to ask for it. And if you are doing family planning, I strongly urge you to consider doing it through a genetic counselor, through a perinatal clinic, because if it is one of the more recognized and available in the targeted genetics or the panels, that will help you family plan and lead to early diagnosis, right? And people always tell me these stories. I hear them every day, right? That they've struggled with recurrent infection for their first 30 years of life and nobody believed them. They were malingerers, right? Like, quit being a whiner. And then all of a sudden you have CVID and your whole world gets turned upside down. And now you have an understanding that you're not nuts. Like, this isn't in your head. That you could spare your next generation that with genetic testing. So I don't hold any stock in genetic testing companies. I don't test all of my patients if they are straightforward. And certainly if they're diagnosed after they have their children, I don't even necessarily screen their children. Because if their children aren't having symptoms of the disease, I don't go on a witch hunt for it.
Right. So is genetic testing for a CVID zebra targeted gene testing?
No, no, it's panel testing.
Okay.
It's panel testing. We know a ton, like TACI and BAFR. Those were two genetic mutations that were identified very early. Gosh, Kathy, you probably would remember we were talking about TACI for the first time at the Como Zoo. The first time we were at Como Zoo here in Minneapolis for an IDF forum. I bet that was in 2010. So that's maybe 12 years. Yes, Kathy, you're raising your hand. Would you like to speak? You have to unmute yourself to speak.
So
yes, Chris, thank you. Yes, I was going to give you a thumbs up there and raise my hand instead, but you are absolutely right. Thank you.
Yeah.
Just a few more questions and then we'll finish it up. But I mean, we've had some amazing questions asked, and I think it's very beneficial for people to hear. So let's talk a little bit about comorbidities along with PI. So what testing would be advisable for a patient who has a slight IgA deficiency and persistent irritable bowel symptoms with fatigue? You have any advice for them?
And the only finding is a slightly low IgA.
Mm-hmm.
So this sounds like a GI problem. So your IgA is an antibody that is secreted in your gut. And so your gut may be causing your low IgA. You may be leaking protein through your gut. And it may all be related to inflammatory bowel stuff. So a gastroenterologist would be a good place to start there. The only real, I don't mean to sound like snooty, but the only real IgA deficiency that I get real excited about from an immune deficiency standpoint or a PIDD diagnosis standpoint is an absent IgA. So someone who has an IgA that is less than measurable. Those are the ones who have what we call selective IgA deficiency. And yes, those patients have GI disturbances because they don't have the protection of IgA in their gut. But somebody who has a low IgA, but present, I normally do the functional workup for those people if they have only if they have recurrent infection. Otherwise, I usually say, it sounds like a GI problem. So that would be my assumption.
And how does IgA deficiencies and skin issues correlate?
They don't necessarily, because that being said, selective IgA deficiency, that population, so if your IgA is 0, you are more prone to dysregulated immune responses. So you may have higher risk for psoriasis. You may have a higher risk for bullous pemphigoid or any type of pemphigoid for that matter. You may have higher risk for other skin-related immune diseases that are caused by immune reactions. But IgA itself, absent IgA itself, isn't responsible for that. It's the immune system that caused the selective IgA deficiency that is causing your immune system to overreact. So I'm going to back up a second. Colleen, you mentioned something about comorbidities. So right now it's hypothesized that 50% of immune deficiency disease is diagnosed as a result of an autoimmune condition being diagnosed first. Mm-hmm. So patients with immune deficiency diseases, specifically selective IgA deficiency and common variable immune deficiencies, are likely to immune dysregulation. And this can lead to the development downstream of autoimmune disease. I'm say a few, but there's hundreds of them. Rheumatoid arthritis, psoriasis or psoriatic arthritis, alopecia, ulcerative colitis, Crohn's disease. I don't know, God, I could go on and on, right? Myasthenia gravis, right? So I could go on and on. those autoimmune diseases are now hypothesized to be diagnosed earlier than primary immune deficiency, which caused it. So your immune dysregulation is at the foundation of all of those diagnoses. 50% of immune deficiency disease is diagnosed after they've had their first comorbid disease.
Interesting. If I have low natural killer cells, does that mean I can't fight viruses?
Yeah, that's what natural killer cell deficiency, NK cell defects, are associated with specifically that herpes family of viruses like EBV and herpes and chickenpox and shingles is a big one. I see a lot of patients with NK cell defects having shingles recurrently. So yes, that's not the only reason people get recurrent viral infections, but that is one of the consequences of having low NK cells. NK cell numbers, however, if you ask an NK cell scientist, are only half of the picture. That you have to look at NK cell function, but that's real hard to do unless you live next door to an NK cell lab in Cincinnati or Washington, DC or Seattle. So there's not many out there that are doing NK cell function, but low NK cells persistently, not just on one or two markers, but persistently low NK cells are associated with recurrent viral infection.
So when you were recently diagnosed and you're facing irregardless of age, but let's say you're younger, or it's your child and they're facing a lifelong infusion, there's oftentimes concern. What does that mean for my health in general, receiving these infusions? Do we know of any long-term issues with receiving Ig replacement therapy?
Yeah, the biggest long-term issue that you'll have to contend with receiving IVIG therapy for primary immune deficiency disease is better health. That is your long-term consequence of receiving and taking your immunoglobulin long-term. Now, IVIG, this is a topic for a completely another forum, but IVIG is a human blood product. So there is always the risk of transmission of human diseases through the plasma proteins that people donate. But right now, our plasma pool is very safe. It's, through viral inactivation, and all of our sponsors could speak to their steps that they take in their products, but they're very safe. But that's not to say that there's not going to be an evolution of a new virus that is not, passed on through the blood supply. But right now, immunoglobulin for immune deficiency disease is the lifeline for the diagnosis and lifelong treatment if your diagnosis is correct.
Well, and I think that's a perfect way to end. Again, I will say, I'm sorry, the questions have been amazing. Kristin, you've been great at answering them. I know Kathy's just sort of going, oh my gosh.
I know.
But
I see so many here that we didn't answer too, and I feel badly that we didn't get to all of them.
But the more we can educate, the more we can help people understand, the better things will be for everybody. So I greatly appreciate you taking the time. For those who are on Ig replacement therapy, I love what you said. The biggest concern you have is better health. And what a wonderful way to look at it in that manner. For those that are not on Ig replacement therapy, there are still lots of options to lead a wonderful life. It is a matter of having a great team, somebody who involves Kristin and people like her, and, speaking up, speaking for yourself, speaking when you think there's a concern, even if it's a friend or a family member and you're concerned about somebody that just doesn't seem right with their health, getting them tested, starting the testing process is that's the first step. And it can be done at your pediatrician. It can be done at your PCP, and then you kind of follow the steps. There is a process. And so I encourage all of you to advocate for yourself. Don't be afraid to speak up enjoy life. And, you know, thank you for being here tonight. And Kristin, you were awesome. And the questions were fabulous.
Questions were great.
If you still are interested in getting an answer, hit that tab on the IDF website and ask IDF, and we'll be glad to answer your question as best we are able.
Just so you know, as a member of the Nurse Advisory Committee for the IDF, we get those questions. So just know that those questions do pass through review. So please submit if you are reaching out. We want you to reach out to us.
Yeah,
not to
that's
Dr.
what
Google.
we're here for.
Mm-hmm. And Chris, I cannot also thank you enough. We have so many wonderful comments coming in through the chat about you, about this program, and I will be sure that you get copies of all of them, and everybody will be getting an evaluation via an email, and I will be sending, I'm sure, hundreds more positive comments to you. Thank you. Thank you. Thank you. And in addition to thanking Chris tonight for volunteering her time to be here.
I volunteered?
Yeah, I know, boy, it's a surprise, huh? Surprise. No.
You didn't read the fine print.
Yeah, I tell you, no, thank you so much. You are amazing. And, you know, as a Minnesotan, we're lucky to have you here in Minnesota with us. And as we wrap up, I would also like to thank our featured sponsors tonight, CSL Behring, Grifols, and Takeda. And thank you, every single one of you, for attending tonight, for sending amazing questions, because those questions make these programs what they are. Your great questions, your smart questions, they enhance this program. So thank you for being a part of it. Thank you for joining us. And everybody, please take care. Have a wonderful evening. And we look forward to seeing you on March 3rd. And apparently it's not on the calendar yet, but it'll be up there. And you'll also get an email about that next forum. So again, thank you, everybody. Take care. Good night.